right, a very good morning, good afternoon, and good evening from wherever you're joining. First of all, thank you for coming today. And I'm Sabu Padmadas. I'm a professor of demography and global health here at the University of Southampton. It's actually quite close to London, so we are actually the South Coast. And I'm also an associate dean international of the Faculty of Social Sciences and a founding director of the Center for Global Health, Population, Poverty and Policy here at the university. I'm also the founding director of the India Center for Inclusive Growth and Sustainable Development. So, as we are assembled today, I think we are actually reminded of an important milestone in human life, which is pregnancy. And this is actually a month of pregnancy awareness. So, or pregnancy awareness month is sort of being widely recognized everywhere. In fact, it should not be a monthly awareness, it should be a yearly awareness. This is what I think. And as we speak, there are about more than 250,000 women die during pregnancy due to maternal or maternity causes, and the most of those could be avoided, could be averted. And the preeclampsia that we talk about today is a condition that affects some pregnant women, and usually during the around the week 20 or during the second trimester or soon after the baby is delivered. And some of these can be very well avoided. Globally, I think we are talking about something between 50,000 to 75,000 women dying because of preeclampsia or eclampsia. And all these could be really, some of these are actually quite difficult to predict, but that 75,000 per year tells us something really big, because imagine that this woman has other siblings, or even on an average, if they have contact or if they have relatives, let's say 4 relatives or 5 relatives, you're talking about nearly quite close to 250,000 or even 500,000 people affected by this condition, because a mother's death is actually completely is irreplaceable, and I think we need to be really paying more attention to that. So I'm so pleased today to be welcoming you to this very interesting conversation on preeclampsia. We have 4 eminent speakers today. So, first we are going to really hear from Dr. Swati Agarwal from the University of Toronto. She's going to bring in more clinical perspective to the problem. Then we have Dr. May Rezai, who's going to really talk about the cost burden of preeclampsia. And then we have Dr. Carolyn Fahm, who is actually going to share with us her experience of preeclampsia. So, when somebody goes through it, then it becomes deep. And then finally, we have Professor Asif Ahmed, who will talk about his research and how we can solve preeclampsia. I'm going to introduce each and every one separately. So may I start with Dr. Swati Agarwal. So Swati Agarwal is a clinical and academic obstetrician, currently working as a maternal fetal medicine fellow at Sinai Hospital, Toronto, and which is one of the best high-ranking or high-risk pregnancy centers in the world. So I think we are really delighted that Dr. Agarwal could join us today to really talk about her clinical experiences. And she has completed her subspecialty training in high-risk obstetrics from St. Michael's Hospital of the University of Toronto. And her clinical work is focused on managing pregnancies complicated by various maternal and fetal issues. And her research work in particular has generated several high-impact publications, because we need research that research intensity in this area should be really high. And Dr. Agarwal's contributions are immense here. And her publications are in the area of fetal medicine and preeclampsia. So she is the right expert to talk about preeclampsia. And she received her master's in reproductive medicine from St. Catherine's College from the University of Oxford. So may I just warmly welcome Dr. Swati Agarwal. May I also request all of you to really keep your microphone and video switched off, but please do interact with us by posting your questions. And we will actually dedicate some time towards the end to to take the questions and to answer the questions. So without any further ado, I mean, may I just invite Dr. Swati Agarwal to share your, her clinical experiences. Dr. Swati, please.
Thank you, Dr. Padmadas, for your kind words. And I'm very delighted to be here. Thank you for inviting me. I'll start with what is preeclampsia. So preeclampsia is a very pregnancy-specific disorder, which is characterized by high blood pressure in pregnancy, along with the affection of one or more organ systems in pregnancy. So, which is, affecting liver or kidney, and also affecting the baby in a pregnant woman. And so it's a very common disorder, as you already illustrated, as you already talked about. It's in high-risk pregnancies. It can affect in up to 1 in 5 pregnancies and up to 1 in 20 in low-risk women. So this makes it one of the most common pregnancy disorders. Most common pregnancy disorders which we commonly see in the clinic. Important now, what are the risk factors who are the women who are more likely to get preeclampsia? So basically there are many risk factors for it. Just being pregnant, as we joke, is a risk factor sometimes. First pregnancy is a risk factor for preeclampsia. So any woman who is pregnant for the first time has a higher likelihood to get preeclampsia than in subsequent pregnancies. Then if you're above 40 years of age, if it's multiple pregnancies like twins or triplets, if have any previous disorder, pre-existing medical disorders like high blood pressure before pregnancy, or any autoimmune disorders like SLE or lupus before pregnancy, diabetes, type 1 or type 2 diabetes. So basically it's a huge spectrum of risk factors. It's making it a very common disorder in pregnancy. And unfortunately, we do not have a lot of, we can predict it, but to prevent preeclampsia, the only medication or only thing which has been proven to be somewhat effective is giving low-dose aspirin in pregnancy. So in any women who we think might get preeclampsia later on, we start low-dose aspirin at the gestational age of 12 to 14 weeks, which reduces the risk of preeclampsia later in pregnancy. It almost reduces by half. And also in such women, we keep a very close eye for signs and symptoms of preeclampsia. At Sinai here, we have a special clinic which is dedicated to all the placental disorders. So any women with previous history of placental disorders or placental disorders in current pregnancy, we monitor them by using blood tests and ultrasounds to diagnose preeclampsia at the earliest. So that's a brief overview. Now, what are the symptoms of preeclampsia? Like what a pregnant woman needs to know about it so that she can present to the hospital at the earliest. So one of the most common things is headache, severe headache, which is out of ordinary, which starts suddenly, and throbbing kind of headache, which women usually describe it as, along with visual changes, which can be a flashing of lights or a blurry vision or seeing objects around eyes is common in preeclampsia. Other thing is severe nausea and vomiting in pregnancy. Pain under the ribs or in the upper part of the tummy is common, which might signify liver problem, liver disease due to preeclampsia. And sudden increase in swelling, like swelling of hands, a sudden increase in hands or feet, size of hands and feet, which women might notice overnight. The other common symptoms of preeclampsia, and unfortunately, some of these symptoms, as you might think, are also common pregnancy symptoms. So swelling is common in pregnancy, nausea and vomiting common in pregnancy. So, but important is if it's something really off, which was not present yesterday, and you see today, that might be preeclampsia. So it's important to go to the hospital and get blood pressure checked and get urine tests and blood tests done for preeclampsia. So once a woman presents to us with signs or symptoms of preeclampsia, first of all, we measure blood pressure and do some urine tests and blood tests and divide preeclampsia into mild preeclampsia or severe preeclampsia. Mild preeclampsia is something which we can manage as an outpatient. So we measure blood pressure regularly and do urine tests to see protein in urine, which is a common finding in preeclampsia, and blood tests to see liver and kidney involvement, and also ultrasound of the baby to see if the baby is affected because of preeclampsia. If it's a small baby, or the blood supply to the baby is affected. So those are the common things which we look for and can manage as an outpatient. Sometimes we also give the pregnant women blood pressure monitors to monitor pressure at home and give parameters that if the blood pressure is above a certain parameter, then to present to the emergency department or the nearest triage right away to get further assessment of it. And the goal is to try to prolong the pregnancy as much as we can to avoid prematurity, which is a further blow over small baby in terms of prognosis for the baby. So we try and prolong the pregnancy as much as we can, and what is safe for the mom and safe for the baby. And if it's a severe, if the preeclampsia is severe, then unfortunately usually it's an inpatient management, and many times we need to deliver the baby, but also our goal is to prolong the pregnancy. So we monitor the mom as an inpatient quite closely, with sometimes even daily bloods and multiple times a day blood pressure checks. We give antihypertensive medications to keep blood pressure into control. Sometimes women might be on 1, 2, or 3 or multiple blood pressure medications to be for their blood pressure to be controlled, and monitor the baby daily using non-stress test and weekly ultrasounds, just to prolong the pregnancy as much as we can. Sometimes they administer steroids to the baby. If the woman is removed from term, then to mature the lungs of the baby, we need to administer steroids to decrease the to improve the maturity of the lungs in such babies. And and ultimate treatment for preeclampsia at this point is to deliver the baby in the placenta. So as we say, preeclampsia is a placental disorder, so delivery of the placenta is the treatment for the disease. So, and sometimes it ends with, theoretically, it should end with delivering the placenta, because that's what is supposed to be causing the disease. But sometimes even in women after delivery, we see preeclampsia. It might linger for a few days to few weeks in some women, and a few months, and some women might end up having chronic hypertension or high blood pressure even outside pregnancy, which might need lifelong medication. And such women are also at risk for getting a cardiovascular or heart problems in later pregnancy. So overall, it has got significant impact in pregnancy and overall health of the women. And such babies who are born small, if they're both born small, they're also at high risk of getting cardiovascular disorders later on, or diabetes later on in their life. Yeah, one of the things which also I wanted to mention is there are few blood tests which have evolved in the past 10 years or so to predict and to diagnose preeclampsia. We call that, they're known as SFLT or SFLT PLGF ratio, which are the hormones which are released by the placenta in a pregnant woman. So these hormones, they help us in predicting preeclampsia. We, in women who are at high risk, we do it early in pregnancy, and subsequently might repeat to see how they're doing. And if they're normal, then to a certain extent, we can be assured that, okay, for the next 2 weeks, this woman is not going to get severe preeclampsia, or can be managed as an outpatient, but they are still under development, these kind of tests. So Yeah, overall, I would like to say that it's a very common disorder, and awareness about preeclampsia is very important, and just knowledge about it and presenting early with symptoms might help in preventing few of the complications, and especially eclampsia, which is seizures in pregnancy, which is a sequel, which comes after preeclampsia. Preeclampsia is not common, not properly managed, then it can lead to eclampsia or seizures in pregnancy. So yeah, so it's important to be aware of this common disorder.
Thank you, Dr. Agarwal. I think, well, that's a beautiful summary of the clinical dimensions of preeclampsia. And of course, I think, as you've correctly mentioned, that, there's quite a lot of complexity and uncertainty in that whole, once it unfolds, I think, and what we need is actually a solution, a drug, and that's something that MirZyme is actually really working hard on it. And we all hope that that day will come true. That's a reality. And particularly, it's not just the University of Southampton. I think many universities across the world should be really working with and supporting that effort. But thank you very much for that wonderful introduction to the problem. May I just now invite Dr. Carolyn Fahm, and it's a great honor to have you, because you have actually, I mean, what I understand, and I think you are really frank about this, that your only pregnancy ended in stillbirth caused by a severe preeclampsia, and even subsequently leading to organ system failure, disseminated intravascular coagulation, and malignant hypertension. So I think it's quite really, really hard. But thank you for joining us from the United States. And Dr. Carolyn Fahm is also a scientist. I mean, she spent her career in the fields of analytical clinical chemistry, quality assurance and quality control systems, both in the US and the UK. And a particular interest and the areas of expertise are immunoassay, tumor markers, trace elements, and the external quality assessment. So I think it's been we are really honored to have you. And may I just invite you to really share your personal experiences before we move on. Thank you.
Thank you for inviting me. Well, my one and only pregnancy ended with what's called HELLP syndrome, which means that there was hemolysis, there was elevation of liver enzymes, and there was a reduction in platelets. The pain that I didn't recognize as preeclampsia was my liver failing. And because of lack of understanding, I didn't attend hospital until the next morning after a night of vomiting. So all the symptoms that you described, Doctor, were present, but I think that the understanding and education of the mothers is absolutely key. Now, what happened to me was I went from blood pressure 110/60. Within a matter of days, it was 210/110. My platelet count went from 400,000 to 4,000 because of disseminated intravascular coagulation. That meant that I was unable to have a cesarean section. I was unable to get a platelet infusion because all the infused platelets would have been used up in the intravascular clotting. And so I went into, the only thing that could be done was prostaglandin induction. Now, this is something I have never discussed with anyone, but I had the cardiac monitor on, monitoring my son's heartbeat. And I was told that his chances of survival were almost zero. So I had to ask them to please remove it because I didn't think I could bear to hear his heartbeat end, hearing him die. The emotional impact, the physical impact, and the fact that I was advised never to attempt another pregnancy tells you this is a devastating condition. I was told that if I didn't begin induction within a matter of hours, that my life and his life would end simultaneously. the dream of my life is for this to be a curable condition, a diagnosable condition, and a curable condition. And this is why I'm so elated to hear what Professor Ahmed is and Dr. Rezai are doing at MirZyme. This is a condition that, as you say, is a global killer of mothers and their children. So as a former preeclampsia patient, I am totally committed to doing whatever I personally can to support the cause.
Thank you, Dr. Caroline. That's that's a very concise summary of what you've mentioned, but I think also your support and for this fight against preeclampsia is very crucial. So thank you for sharing your experiences.
Well, I was one of the mothers that has had lifetime of medication for hypertension. I don't believe my blood pressure has ever really gone down from what it was. It's just barely controlled, and sometimes it's out of control on 3 different types of medication. And so that's a complete worst case scenario. So I am obviously at high risk for cardiovascular complications and stroke.
Right. Thank you. Thank you. I think we will definitely
So can I just ask Carolyn to share her story of the incidents when it happened, if she's willing to? I mean, she's told me, but it moved me, and it made me more determined than ever before to make sure preeclampsia is that we make it history within this decade.
Well, my situation was going into total. When I left the hospital, I weighed considerably more than when I went in because of massive edema, cerebral edema, corporal edema everywhere. I had, as a matter of fact, I was discharged and had to be readmitted the next day because I was still going through as you say, the preeclampsia did not end immediately with the delivery of the placenta. It was the end of a dream, because I think we all look forward to seeing our families grow and to have it not survive and to have it not be possible to continue the quest. It's a devastating thing for both parents. The situation became so apparent to me that when I noticed a pregnant colleague with swollen ankles, I said, please call in and report that. She was told, wait for the weekend to be over and then we'll check you. I said, no, don't wait, go in right now. And her blood pressure was 220 over 120 and she arrived. So I think that awareness of preeclampsia is, one of the most important things, but the truly important things is once you detect it, to be able to cure it. And also to be able to do it in a non-high-tech setting globally, because every mother's life is equally precious. There is no hierarchy of worth of any human being.
And you told me about that you could not arrange for the funeral. I don't know if you want to talk about that because that stuck in my head ever since. And it was especially during the pandemic when people couldn't see their loved ones, and it doubly amplified it because some members of my family had that sort of experience as well.
Well, I think that, yes, being alone in that room, I have to tell you, though, that when I was in that room, it turned out the that it was a support group right around me, because my doctor, my midwife, and another person in the room, they had all lost their firstborn children for a variety of reasons, and 2 of them were preeclampsia. So it was a remarkable experience in many ways, and I don't think I hope that other people don't have to go through it, but just by a blessing perhaps, I was surrounded by people who understood what I was going through and what it meant, and because they had experienced it themselves. So in a way that just shows that preeclampsia affects many people, but the situation of having your child, you'll be having a silent delivery where the only sounds are the cries of the mother. It's a cold, still, silent birth, and you're handed a baby, and that baby is ice cold, never to open his eyes. This is what preeclampsia means, because that is the only solution. Delivery of the placenta, whether the baby is ready or not.
And which can be considerably, life-threatening, and and as you've correctly said, in most settings in today's world. And you also made a very important point regarding the hierarchy. I mean, there is no hierarchy. Well, mothers, wherever they are, everyone, has that right to, to go through, to experience a safe pregnancy and deliver a healthy baby. So I think, but on the other hand, I think, that the whole challenge, I think it remains a challenge within the kind of medical community, and that needs to be so. The events like this, is aimed to really promote that awareness, and then also help. This will also help both practitioners, I mean physicians, as well as the patients. I mean, although not patients, the pregnant women, to really think about this and reflect, and then and be ready to face it. I mean, if it just happens. So I think these are really very important experiences that you've shared, and thank you. And I think we'll definitely follow upon this. But may I now just invite Dr. May Rezai, who is actually going to really talk about the cost burden. I mean, of course, the cost of that life is there's no, I think, we can't replace that, but I think there is a tremendous cost burden of the preeclampsia condition. And that's where I was referring to at the introduction, that it affects families, it affects the partners, it affects the husbands, it affects the mothers, sisters. So it's really, it's something that that has a much wider impact, and also on healthcare systems. I think in most healthcare systems today, as we see, they're ill-equipped. I mean, sometimes for emergency obstetric care facilities, most health systems in the world, they don't have that provision. So there are huge challenges. But Dr. May Rezai is currently the Chief of Staff and Operations Lead at MirZyme Therapeutics, and she's also been involved with the company since its inception. So that's very important. I think her commitment stands from that start point. And Dr. May also has a PhD on preeclampsia, and her work has generated several high-impact publications focusing on validating the potential of novel therapeutics based on the kind of current work that has been undertaken by Professor Asif to prevent preeclampsia and other outcomes. So without any further ado, I think may I just invite Dr. May Rezai to really share her reflections on the cost burden of preeclampsia. Dr. Rezai.
Thank you, Professor Sabu. Thank you for Caroline as well as Swati for giving their insights. And Caroline's story and stories like hers is the reason why I want to dedicate my life to working for pregnancy complication, to ensure that mothers won't have to go through the experience that Caroline did. And the global cost burden, or the cost burden in high-income countries I'm going to be talking about today, but it's just a reflection to show that how expensive it is to have a pregnancy complication, and why it's so important for us to have solutions for this, so people in low-income countries will be able to have a safe pregnancy, as well as people in high-income countries. I am going to share a couple of slides. I hope that's okay with everyone. Bear with me for a second. Can you all see my screen?
Yes, you can see.
Great. So as Dr. Swati explained, preeclampsia is a pregnancy complication, and it affects 1 in 12 of 131 million pregnancies around the world. It is responsible for over 76,000 maternal deaths and 500,000 of infant deaths a year, and this equates to a life lost every minute. The prevalence of preeclampsia is different around the world, and the table here shows the estimated number of preeclampsia cases in different regions and countries, with the highest being in China, of course, which reflects the population. I have only included a couple of examples of high-income countries because, as Asif mentioned, we have another webinar next week to talk about preeclampsia around the world. So the direct global cost burden of preeclampsia is around $100 billion. And this is direct cost, which includes long hospitalization and more doctor visits. And Dr. Swati also said that the high-risk pregnant women are monitored more closely with more blood tests, ultrasounds, and extra tests. And this is the direct cost burden, which we have there. So a study data were drawn from a national de-identified administrative database in America of over 45 million individuals who had commercial insurance, and they looked at the fetal cost for the first 6 months of their life. And then I just wanted to point out the mortality rate of babies who are born at different weeks of gestation. So, for example, if you have a baby who are born at less than 24 weeks, the mortality rate is 60.4%. And we know one of the main consequences of preeclampsia is preterm birth, where women deliver before term. And we can see here that, of course, the mortality rate among different weeks, birth at different weeks is different, and this decreases as we see increase in the gestation as the gestation goes up. Excuse me. However, the mortality rate overall is still as high as 3%. And as Dr. Swati mentioned, the main aim in the clinical setting is to prolong gestation to ensure that the baby can develop fully before we deliver. But unfortunately, this is not possible in most cases of preeclampsia, and what happens is that the baby gets delivered quite early before term. So we extrapolated the data from the previous paper or data that I showed, and we looked at the national cost of preterm birth in America, and this equates to $24.3 billion in the first 6 months of infant's life. And because only 10% of the preterm birth is due to preeclampsia, and this equals to 2.5 billion of this preterm cost in USA because of preeclampsia. Preeclampsia also causes small for gestational age babies where their weight falls under the 10th percentile, and so they're growth restricted. And the prevalence of small for gestational age babies is around 11% in high income countries, and this is one of the main causes of prenatal and neonatal morbidity and mortality with long-term health consequences. 25% of preeclamptic babies are growth restricted. And again, we can see here that the average cost of small for gestational age babies for the first 6 months of their life is around over $100,000, which is costing America a total of over $25 billion a year. And preeclampsia accounts for more than $6.4 billion of this costing. An epidemiological and econometric method was used to assess the annual cost of preeclampsia in mothers in the United States and found that the maternal cost of preeclampsia was around £29,000 per case per year. And this was used using Medi-Cal, which we know is one of the cheapest healthcare system in America. And we know that in some states, such as New York, this can be 2 to 5 times higher than that. But with that conservative figure, we can see that the annual maternal cost in America is $5.6 billion US. And America also has one of the highest maternal mortality rates among high-income countries, as high as 17.4 per 100,000 pregnant women. But so far, we've only looked at the short-term financial costs. But we have to understand that there are a lot of long-term health consequences of preeclampsia, which with that comes the financial cost as well. One of the, in my opinion, one of the factors that we have not looked at is maternal mental health, which affects 1 in 5 mothers. And 20% of mothers suffer from postpartum depression and postpartum anxiety. 3% of mothers suffer from postpartum obsessive compulsive disorder, while 9% of mothers suffer from postpartum traumatic stress disorder. And we also have around 1/4 of all maternal deaths between 6 weeks and a year after childbirth are related to mental health problems, which unfortunately there hasn't been a lot of focus on solving that problems. And we know that preeclampsia significantly increases the risk of mental health disorders among women due to traumatic experience of preeclampsia. And maternal mental health problem costs the UK over £8.1 billion a year. So it's costing us a lot of money, given that, you know, NHS is quite cheap, one of the best healthcare systems in the world. And we also note that women who have experienced the preeclampsia are 4 times the risk of getting heart attacks, 4 times risk of heart failure, they're 2 times more likely to get a stroke and 2 times more likely to get vascular dementia. And all of this, when we talk about the cost burden or the financial cost burden of preeclampsia, none of these are taken into consideration. And premature babies, of course, have a lot of problems all the way up to their adulthood. So breathing problems, heart problems, intestinal problems. They've also shown that they have lower IQ compared to babies who are born from normal pregnancies. The other thing I wanted to also talk about a little bit is the disproportionate or the inequality. The number of women who are affected by preeclampsia seems to be higher in the women from ethnic minorities in the Western countries. So African-American women with preeclampsia are at an increased risk of preterm birth, which results, of course, we talked about in low birth weight infants. Uterine fetal death among African-American preeclamptic patients are also twice as the rates in other races. On the maternal side, African-American mothers with preeclampsia have more severe hypertension, antepartum hemorrhage, and increased mortality. And those who survive preeclampsia have a high risk of postpartum cardiometabolic disease as well. The severe maternal morbidity is also significantly high and more common among non-white women in the UK. So the risk of severe maternal morbidity in non-white women, I think, is around 126 cases per 100,000 compared to 80 when it comes to white women. And a Black mother is 4 times more likely to die as a direct result of pregnancy or childbirth compared to their white peers. And a baby from a Black ethnic group is more than twice as likely to be stillborn. So we really need to look into the long-term complication of preeclampsia and the cost burden of this when we talk about the financial cost burden. I would be happy to talk and take any questions after Professor Asif Ahmed's talk.
Thank you, Dr. May Rezai. I think that was a very beautiful illustration of the data that I think we want to see, and I'm sure that, I don't know how many of the health leaders and government authorities know about these. I think or how often they check these data becomes a really important question. And also you highlighted one of the critical long-term implication, not just in terms of the impact on non-communicable and chronic diseases, but also mainly, including mental health. I think that's something that has not been really well addressed, although we know that we tend to really kind of see the mental health impact of after pregnancy relating more to the postpartum depression, but this has definitely long-term consequences. And I think we have also sort of had, we could feel that also from Dr. Carolyn Fahm when she was sort of highlighting this. Thank you very much for your beautiful presentation. Thank you. That was very useful. May I now just invite Professor Asif Ahmed to talk about his research that he had spent over a quarter of a century work actually on this, and with the particular passion of really, he wanted to really find out that how can we really, what can be done actually to save women while giving birth. And he and his team have found ways to reduce the risk of mortality and morbidity in pregnancy. So Professor Asif Ahmed is a renowned vascular scientist and an inventor of protective pathways and his research has led to a better understanding of the protective pathways to prevent preeclampsia. He's currently the executive chairman of MirZyme Therapeutics, and he's also the senior advisor to the president and vice chancellor of the University of Southampton, so that we are very lucky to be working with him. Professor Ahmed has also been a full professor for almost 25 years. Scientifically, he has over 27,000 Google Scholar citations, and according to the Stanford Study 2020, he is definitely in the top 2% scientists in the world. So that's really, we are all very proud of. He's also the founder of Aston Medical School, the most socially inclusive medical school in the UK. He has also held various positions, including the executive board position and NED for a decade for a number of organizations. He's also the founder of Aston Medical School in the UK. So I think his CV goes on for a long, but I think I have had personally the pleasure to work with him over the last couple of months, but particularly, and I have found this enthusiasm is really very inspiring. And I think in this level of enthusiasm, I'm sure that we will very soon find a solution, a drug to reduce and to get rid of this preeclampsia conditions. So may I just invite Dr. Professor Asif Ahmed to give his presentation. Thank you.
Thank you, Sabu. You're too kind. Professor Sabu is one of the pioneers in global health, big data analysis, and not only that, he's also a very kind and person who is always available, no matter what time I WhatsApp him, and he's willing to have a conversation and discuss ideas. So I'm really grateful. And University of Southampton, the reason I align myself, although I'm in Birmingham, with Southampton, because it's one of the world's leading global research intensive university, but also is very much into inclusivity. And that's something that's very close to my heart. And we just did a mental health program between Yale and Southampton. And I remember the Vice Chancellor saying to me, let's not talk about it, let's do it. And so it's the agile ability to do things fast is what appeals to me. So, well, today we're really celebrating or remembering that it's a Preeclampsia Awareness Month. And what Carolyn just said, it's been in my head since she told me first time. And there have been a number of cases where I've come across and people have told me things that has motivated me. And I guess the real motivator at the very beginning of all this discovery thing was my daughter when she said, Daddy, you talk about VEGF, but what have you actually done? And that was a chain reaction that started in 2006. So what I thought I'd do is I'll share with you on the pathophysiology from our perspective, why I think we have solved this problem. So over the next 20 minutes or so, 100 women will die because of preeclampsia. So that's a fact. Well, because of pregnancy complication, I should say, really. But one of the major causes of that is preeclampsia. You've heard enough from both from a financial cost, personal cost, and the management that is taken. But despite the management at one of the best institutions, they can't solve preeclampsia. So that's the point to remember. The very best places or the low-income places, preeclampsia is not solved. And even predicting it is not, what Swati was talking about was predicting to rule out, but to rule in is a different story. And we believe we've solved that problem. So let me just share with you my screen. I hope I can. And what I will do is, I hope everyone can see it. So
yes, we can see.
You can see it, yeah? So preeclampsia is a condition in when you get high blood pressure in the mother and multiple organ damage, as Dr. Carolyn said, and undersized baby. Those are the kind of conditions, and about 11 million women every year get it. But what I want you to think about is which is more risky, flying is safer or having a baby? I can tell you flying is safer than having a baby. And because roughly 5 of those, if one airplane falls down from the sky, it's on the news in every newspaper, in every channel around the world. But just imagine if 5 were falling from the sky every week, every year. Will you fly? So I want you to remember that we need to solve this problem. And our mission is to make preeclampsia history within this decade. And it's not just affecting the developing world, it actually affects, there are health inequalities and affects the most developed worlds. In the United States, in New York City, if you're a Black woman and you're pregnant, your risk of dying from pregnancy-related complication is 12-fold, which was shocking news for me. And preeclampsia is on the rise. It's on the rise. Why? Because women who are college educated are choosing to have children later in life. It's because they're using their 20s to build their careers. And in the mid-30s, they're having to have children. And that increases the risk by 4.5-fold. In addition to that, the risk is double due to COVID. So if you have COVID, your risk of pregnancy-induced hypertension is twice. And you've heard from Dr. Swati about diabetes, obesity, various other risk factors. But women should be able to have children in their mid-30s. And we want to give that choice. So our vision is to empower women to transform lives, because the first woman to transform your life or the person was your mother. And we want to make sure that all would-be mothers become mothers. And how do you do it? So what we need is a rapidly developed, new, affordable, medically targeted therapeutics for preeclampsia complication that can be globally used with relative ease, not just for fancy stuff that is restricted to fancy hospitals. And that's why you need one test, one pill that saves 2 lives. So what's the basic science behind it? There are 3 protective enzymes in our system that we've been working with. You've heard of nitric oxide, which plays a role in dilating blood vessels. But there are 2 other enzymes, which are called hemoxygenase 1, which produces carbon monoxide. It breaks down heme, and cysteine gamma lyase, which takes cysteine and makes it into hydrogen sulfide. These are small gaseous molecules, nitric oxide, carbon monoxide, and hydrogen sulfide, which are signaling molecules in our body, although they are poisonous and pungent in atmosphere from pollution from cars and lorries and stuff. And one of the main culprits of preeclampsia is a protein called soluble FLT. You heard that from Dr. Swati and from, I think, from Dr. May Rezai. And soluble FLT is a natural antagonist of vascular endothelial growth factor, the growth factor that I had been working for many years, since 97 and or 96, 95. And my daughter had said to me in 2006, you work on VGF, but what have you actually done? And that started that chain of reaction. And what my lab had shown back in 97, that VGF binds to a receptor called receptor 1, VGF receptor 1, to stimulate the release of nitric oxide. We were the first to show this. Subsequently, a number of groups, including ourselves, showed that soluble FLT inhibits this and is raised in preeclampsia. And a group showed that this goes up before the onset of preeclampsia. And what that results in is that VGF and placental growth factor, another family of VGF, gets mopped up by this soluble FLT. And the receptor is also inactivated. And that leads to vascular dysfunction. The homeostasis of the blood vessel, the lining of the blood vessel, is compromised. And that's the fundamentals, if you like, of. But the question then becomes, what controls this soluble FLT? Because it goes up normally in normal pregnancy as well. It's tightly regulated. And we were the first to show that removal of this culprit protein, S-FLT, restores functionality to in an in vitro setting. So this, what we've shown on your left side, you're seeing is blood vessels being made into a test tube in a petri dish. These are endothelial cells, that lining of the blood vessels. If you put conditioned media from healthy placentas on them, they grow into nice tube-like structures. But if you put preeclamptics, the purple bar you see goes down in preeclampsia, which is PE. And if you remove that single protein from that by precipitating it out, and then put the growth conditioned media back on those cells, they grow back up, as shown by the yellow bars. And this shows that just removing a single culprit protein restores that function. And another group have used that principle, to use a pheresis method, like a dialysis type machine, where they can pass blood across this and reduce, trap this protein. And it does have some benefit, but it's a high risk strategy, invasive, etc. It's not like a pill or a jab. And the question then became for us was, how does soluble FLT is regulated? Well, one thing we know, that women who smoke or women who chew tobacco are not protected from preeclampsia, but women who smoke, in particular in the second half of their pregnancy, are protected from preeclampsia. Not that we advocate smoking as a therapy, because it has huge negative consequences. But the reason is this enzyme hemoxygenase, which produces carbon monoxide, which is cytoprotective. And my lab, a decade before that data came out, had actually proven that this enzyme is protective in the placenta. And this slide, what this shows is that on the y-axis is cellular damage, and we've got bits of placental tissue in Petri dishes and then exposed to different things in the presence and absence of a damaging protein called TNF-alpha. It's a cytokine, like what you see right now in COVID is going on. And this cytokine causes damages. You can see the levels go up. But if you give an inducer of the hemoxygenase, it brings it down, it protects. But that doesn't mean it's causing cause and effect. What we then did was we put in the presence of the inhibitor of hemoxygenase, SNPP, and you can see the ability of hemin to protect the cells is lost. So we knew that we had identified a placental specific hemoxygenase that was protective. But that was, and then I forgot about it, to be honest, till my daughter reminded me that I need to do something not for me, but for other people. Me, we, as we now, in the great words of Muhammad Ali. And so we then looked at it with more modern tools. So this is gain of function, loss of function. So you overexpress the gene hemoxygenase into endothelial cells, or you take it out, which is the siRNA. And what you see is that if you overexpress it, the cells produce less of soluble FLT, the culprit protein. And if you take it out, it produces more. And then subsequently, we also discovered another breaking system, the cysteine gamma lyase, and it does exactly the same. And both papers are published in Circulation. And so what that led us to identify the downstream events and upstream events. We've tried starting to dissect out the roadmap that leads to preeclampsia and how we can prevent it. And that's what basically we've done. So we've identified that these are upstream events, and if we can work out targets at that level, then we will be able to develop therapeutics. And that's exactly what we've done. And one of the things that upregulates that protein is a pravastatin. And we've just done the world's first randomized control trial to show that we're on the right track. This is more like a shotgun approach because it's not targeted, and this is a category X drug. But what we saw was there was a trend towards increasing gestational period, so prolonging the preeclamptic placenta. But although this was not statistically significant, it wasn't powered for that. But what it did show that we're on the right track. And in the last 18 months or so, as you know, the world's been turned upside down with COVID and pandemic, and now within 12 months, vaccines have been developed. But the vaccines use two approaches. One is a liposomes encapsulating mRNA. Another is an adenovirus that has a sequence of the mRNA. So what we've done, we've used the same two approaches, but with a microRNA. These are things that we've identified that are between the protective enzyme and the culprit protein that directly target the third prime end of the culprit protein. And using both this approach, we've been able to show that it leads to a reduction in the culprit protein and improvement in pregnancy outcome. So the current approach is basically, as what Dr. Swati said, is to give antihypertensive drugs. You can put women who are at high risk on a low dose aspirin, and that has some benefit, but it also has side effects. Aspirin is not, has some side effects, as you know. So the question then becomes, what can we get which is easy to use and highly effective? That was the thing. The people have tried various trials have happened on anticoagulants, stem cells, immunotherapy, and these have been extrapolated from other diseases. But preeclampsia is a pregnancy-specific disorder. And therefore, you need to work out what's going on in preeclampsia, not what happens in other conditions. And as I said to you, the plasmapheresis approach does have some benefit. It removes the culprit, but then the culprit comes back. So you have to keep removing it. So it's a continual use of it, and therefore there are high risks associated with it. I've already told you about the pravastatin approach, which is easy to use, but its effectiveness is going to be not as good, but we have deliberately think it may be used when the other alternatives are not there. But really what we want to do is leapfrog to a position where it's globally accessible, easily usable, and highly effective and safe. And this brings us to our small molecules and the vaccine type, the delivery system that I just spoke to you about. And we believe we have those now. And our solution is taking a very integrated approach to predict, detect, prevent preeclampsia. And so women halfway through pregnancy will come to have their blood test. And even today, we've done the 400-500 patient prospective study where we can predict with 98% certainty who will go on to get preeclampsia. That's to say that out of a 100 pregnancy, 98 who will get preeclampsia, we can predict today. That's a rule-in test rather than a rule-out test. And this allows us then to differentiate into predict those who will get preeclampsia, which makes up 11 million global population, and also to target small for gestational age, which is about 19 million. And that affects 1 in 6 pregnancies around the world. And 25% of them are in the Southeast Asia. So I'm totally committed, as are people in my team, to making every pregnancy to be a safe and joyous. And I hope we can do that relatively soon, because what we've heard from Dr. Carolyn reinforces the urgency with which we need to act. Thank you very much.
Thank you, Professor Asif Ahmed. I think that was really a very interesting presentation. And I think although you touched upon all the, all the kind of solutions and so on, but I think what is far more important is the kind of a very thorough risk profiling. I mean, in terms of really making sure that, well, you made a very clear point that it has to be safe, and it has to be also it has to be affordable, I think, to the wider population. So I think it's a fantastic kind of development, and we all hope that very soon, I think that this comes into a reality. But now, thank you all. Thank you to all speakers. But we do have now a few few minutes actually to take some questions. And I think I'd like to really first, please, those who want to really ask a question on the microphone, please, you may, you may switch on your video and come on board. But I have a question, which is actually to both Dr. May and Dr. Caroline. This is actually from May Rezai. It's actually regarding what advice would you give to women who are planning to get pregnant, given the risk of pregnancy complication, such as preeclampsia? So this is actually a very, very interesting question, because I mean, we have really talked about certain symptoms and danger signs associated with pregnancy, and also the conditions, I think, that can be life-threatening. But the question is regarding that, what kind of, how can we really better inform, how can we raise more awareness on preeclampsia in that wider community? So
well, let Caroline answer that question first.
Yes, please. Yeah.
I think that one of the things, it's a balancing act between frightening people and informing people. And I think perhaps Dr. Swati can speak on this, how you clinically speak to your patients, especially the high-risk patients, because I myself completely missed that the upper right quadrant pain was a sign of preeclampsia, and I will never know that, had I gone in earlier, perhaps the outcome might have been different, although it's unlikely.
I totally agree with Carolyn. It's mostly talking to pregnant women about preeclampsia at their booking visit, making them aware about the condition, because most of the women don't know about preeclampsia until they get it. That's the time they know that this condition exists. As Carolyn just said, that if they were aware about these symptoms, they would come earlier. So I think the main thing is just talking to them in the preconceptional counseling or at the time of their booking visit in pregnancy. And such webinars, which is organized today, will also be helpful in increasing the awareness. This is a great initiative.
I also agree with both, and I think the other thing we can see is a huge increase in the use of internet and resources that's available online. I think it's really important to know, for example, we have Preeclampsia Foundation, we have MirZyme, and we have other charity organizations as well working to raise awareness of preeclampsia. I think it's important for women who use internet, social media, to be able to get onto these pages and to educate themselves on pregnancy complication and the risk of pregnancy complication, not necessarily just preeclampsia, but also other pregnancy complications, miscarriages, early pregnancy loss, placental abruption. As Asif always says, pregnancy is a risky business, and preeclampsia is one of the major risks for maternal as well as fetal morbidity and mortality. So it's incredibly important for women as well as men. I'm not just saying women, because men are the fathers. They will have to look after their wives or partners, to be aware of pregnancy complications when they plan to start to have a family.
Thank you, Dr. May. Dr. Asif, I think I have a quick question, regarding a follow-up on that. I think this is regarding, you mentioned certain risk factors, such as smoking and, a few other, and also the demography, the demographic landscape is changing, and particularly in Europe, that we see postponement of births and so on. To what extent, I think, will those changes, kind of impact the outcome, like preeclampsia outcome?
Well, I think, smoking is not so much, it's a risk factor in pregnancy, but it does protect against, and the reason is the enzyme we discovered suppresses the culprit protein. So they've already shown that women who smoke, they have a lower levels of the culprit protein, S-FLIT, than women. So what I always say, it's when you take it below a critical threshold, preeclampsia will not happen, but fetal growth restriction will happen. So there is so it's a dose and duration of exposure is important. In terms of demographics, as you know, as I said, women are choosing to use their 20s to build their professions, and why shouldn't they? They need to be. So we need to come up with better ways of providing the opportunity for women to be able to do that and not have the fear of preeclampsia. So I don't want my daughter or Swati or May to have the fear to think about preeclampsia when they decide to have a child. And I believe that, and for me, the reason I'm so passionate and forceful about obsessed is the word. I think my wife said, you're obsessed. And the obsession is because I know I can solve this. So that makes it doubly incumbent on me to make sure, when I say I, it's not me, actually it's people like May and Dr. Swati and other members of our team who've done the hard work. I'm just connecting the dots. And so, so I think, demographics is changing. And the other thing people forget, especially where the aging population is, if you lose a pregnancy, like you said, this is people who are working women, you're losing trained professionals' life. And if you're losing babies, then your aging population is going to get even older, right? Because so that's another reason for really putting our efforts to make this happen.
Yeah, because, well, I think I was really taken back to one of my experiences while I was advising the Ministry of Planning and Health in Rwanda. I think the health minister was talking to me, and she was really making a comment that the women who are really turning up in clinics for antenatal care, they are manifesting increasingly, diabetes, and this was actually probably about 8 years ago, diabetes and hypertension. So the hypertension as a condition is probably pre-existing in some women, but probably without knowing as well, because sometimes that sometimes it can be quite latent for a while. So there are these challenges, and of course on the other side, I think we have also very increasing public health concern of rising obesity rates among women. I mean, that's even although there are some some associations with other factors and so on, that's also equally a concern.
Yeah, sure.
Yeah.
It will be good to, I know people have put their questions in the chat, but it'd be good for people, let's encourage people to ask the question themselves.
Yes.
Because we've made it open so people can mic themselves, put their picture on if they're comfortable to put their picture on. I would love to have a picture of everyone together at some point. Yeah.
Indeed. Yeah. So Fatima wants to ask a question to Dr. Swati. I mean, Fatima, if you're there, please switch on your microphone and video, and then you may ask this question. This is regarding the administration of low-dose aspirin as a means to prevent. So, do you want to ask, or I'm also happy to read out that question for Dr. Swati. Right, I think
Fatima might not have a mic, as I see.
Oh, right. Well, let me please read that out. So it's regarding the use of low-dose aspirin to prevent preeclampsia, and the literature shows that it's only the effectiveness is about 14% in actually the prevention of preeclampsia, but also it can actually cause gastrointestinal problems. So the question is, how do you decide who should go on low-dose aspirin for prevention of preeclampsia?
That's a very important question. And
great question. Great question.
Yeah, and Professor Ahmed already touched on it. So it's not it reduces the risk of more severe preeclampsia rather than mild preeclampsia, and also it needs to be started earlier in pregnancy, and therefore literature is quite varied from prevention as low as 50% or 30-40% to up until 80-90%, just because it's not possible to predict preeclampsia in every woman, and they start them on aspirin, and it's also not very effective. But yes, NICE, almost all the guidelines all over the world, including NICE, they have classified the risk factors as minor risk factors or major risk factors. And if you have 2 or more minor risk factors, which include age, over 40, first pregnancy, multiple pregnancy, high BMI, family history of preeclampsia, these are the minor risk factors. Or 2 or more minor risk factors, or 1 major risk factor, which would be previous history of preeclampsia, chronic hypertension, kidney disease, a history of a medical history of lupus or any autoimmune disorders or kidney disease. These are the major risk factors. So any women with even one of these risk factors, one of major, 2 of minor, we start on aspirin from 12 to 14 weeks of pregnancy. And up until 36 weeks of pregnancy, hopefully the pregnancy continues until then, to start on aspirin. There is also literature about 1 tablet of aspirin or 2 tablets of aspirin, and recently most of the studies have shown that 2 tablets of aspirin are more preventive in preeclampsia rather than 1. But definitely it's always risk versus benefit, as Fatima is asked, and as Professor Ahmed has already mentioned, there are some risks to taking aspirin too, but we've seen the risk for preeclampsia much higher than the risks of aspirin. So so definitely we recommend taking aspirin in high risk population.
I would add one more thing, that there isn't a effective therapy. I mean, when people are being asked to take aspirin, it's around 14 weeks. They can't predict preeclampsia at 14 weeks. They can't even predict preeclampsia per se. There's no one can come to me and say, I can predict preeclampsia. What they can do is they can diagnose it, that this person will not get it, right? So it's ruling out, it's not ruling in. What we've done is by working out the roadmap, we can predict, if one member of my family was, pregnant, I know what test to do. But even though it's not approved, right? So that's the difference. And so, therefore, but then what's the point of doing a test if you can't then provide a therapy? So you got to get the two things. As Carolyn said, it's not just about predicting, you got to have a prevention. So you got to be able to prevent it from happening, and you got to be able to treat it. So those are the things. So it's taking an integrated approach is really important. And that hasn't happened till now. And that's why we're very excited that we believe we can do what we've said to do. And as you know, I'm like a dog with a bone, obsessed, and I don't give up till it's done. So Fatma is right, and I think, but we're working on it to make sure that people in the future won't have to rely on that as a potential treatment.
Yeah. Thank you. We have a question from Pavan Kumar, but I think the question, may I just request you to turn on your microphone and ask the question, please? Yeah. The question on the chat is not very clear. So it's about at what gestation do you start and stop the pill? So I think if I understand correctly, I think it's more really like, you're asking that, when can one start, for instance, a pill, for example, aspirin, and when should they stop? In which, during the gestation?
Yeah, I think if I understood this, that question is, and Swati can come in and what they do right now, but I think it's a question about we would do it till in our case the therapeutic is to do the test, stratify the patient, and then give them the pill or a jab, which will then be there for till they deliver. I guess that's what you do now, isn't it?
Yeah, for aspirin, yeah, exactly. So we started around 12 to 14 weeks and continue up until 36 weeks usually, and stop at 36 weeks.
Thank you. So there is actually a question from Alia Abbas asking a question about the quality of life in women and children who have been impacted by preeclampsia. And I think that's definitely the question for Dr. Carolyn. And what is the data in this sphere? So this is actually, we're talking about panel data, like, cohort data or observation data. And I think in this regard, I think I'm also reflecting on the fact that, people like Dr. Carolyn Fahm are actually the global ambassadors of preeclampsia. And I think that's something that perhaps I think, Dr. Carolyn, I think you're the right person to answer that question. How does that affect the quality of life in both mothers and the children, who have been impacted by preeclampsia?
My quality of life was severely impacted. There was the health effects on me, having to, I'm pleased to say that my kidneys recovered, my liver has recovered, my vascular system has not, and this is a lifelong epic trying to get my blood pressure into control. Now, this is an interesting thing, is that doctors, adult medicine doctors are not aware of the vascular impacts of preeclampsia. I'm the one that has to inform them that the hypertension that they're treating now is something that came from a pregnancy years ago, because it's not well known. The emotional impact is of going through grief. Baby loss, stillbirth is it's shattering. It's the experience of an end of, instead of planning the baby's life, you're planning the baby's funeral. Now, I actually couldn't attend my son's funeral because I was still in hospital. And
yeah, I think it has definitely long-term implications, and hence the prevention is of critical importance. Absolutely. No, I think so. We have a few more minutes. I don't know whether if anyone who is in the audience would like to really ask a question. Because I love research. There was also a question about what kind of data. So these are really something that excites me, not just for the reason of really data's sake, but also some of these data, there could be solutions within those data. So one question that I have for Dr. Swati is that well, we know that the kind of sometimes women experience. So the question is more about the parity effects of just like well, we know that, for instance, C-sections tend to the repeat and so on. So to what extent parity plays a role? I mean, because well, in high fertility countries like Nigeria, Niger, and so on, I think there are lots of challenges there. And in fact, those are the places where most women die during childbirth, probably without knowing that they had this condition. So please, Dr. Swati.
So if I rightly understood, you're saying like if multiple pregnancies, if they're having many pregnancies, and the risk of having preeclampsia is also high. Yeah. That's exactly, and that's why the burden of preeclampsia is very high in the low resource countries as compared to the high resource countries. And definitely first pregnancy is a risk factor for preeclampsia, but if you have preeclampsia in first pregnancy, then your risk of having preeclampsia in subsequent pregnancies is way higher. Up to 1 in 5 women who are having preeclampsia in early pregnancy get recurrent preeclampsia, and with every pregnancy, just preeclampsia can be worse and and present more early in pregnancy than the previous one. So totally the burden in those countries is very high, and that's where Professor Ahmed's easy to use diagnostics and therapeutics play a role, because in the developed countries we can monitor them more closely. We have the luxury to monitor them and to admit them in the hospital with close follow-up, but this is not available all over the world. And it's definitely the low risk especially for the high resource, but especially for the low resource settings, those diagnostics and therapeutics would be a blessing.
I think we have slightly have run out of time, but Dr. Asfia, would you like to really ask this question?
Yes, so hello everyone, and thank you so much to Professor Asif and to everybody, to the team. It's really helpful. I'm actually a doctor in the UK, a GP with an interest in preeclampsia. I have a lot of patients who we see, prenatally, antenatally, postnatally. And I've got a strong sort of passion about lifestyle medicine as well. So I do a lot of prescribing lifestyle medicine. And I just wondered whether the two could be intertwined in terms of what you were saying, that, the risk factors with the COVID, the diabetes, the obesity, whether that should also be an element that we kind of push with this awareness, and the fact that it does need a treatment, but that I just feel that lifestyle gets pushed to one side. And I think it should be raised as something that goes part and parcel with what we're doing. Thank you.
Thank you, Dr. Asfia. Anyone would like to take that question?
Sure, I can take that question. So that's a very important point. I think we're focusing on the primary prevention of preeclampsia, like preventing preeclampsia from happening, rather than treating it or preventing the complications of preeclampsia. So I think this is what can bring one of the biggest effect or changes in the prognosis, not just for preeclampsia, but with various problems we see in pregnancy related to diabetes and obesity and not chronic hypertension, not well managed. So definitely a general awareness will help with it. And in high-risk patients with obesity and diabetes, a preconception counseling for them is so that before before they're planning pregnancy, just visiting their doctor, midwife, to talk about their risk factors and what they can do to reduce, to make their pregnancy a joyous experience, like how can they reduce weight or control diabetes and maintain their normal sugars or normal blood pressure, and any risk factors or any autoimmune disease if that's not controlled, kidney disease which is not controlled. So these are like really important points which need to be emphasized and emphasized on, and agree that these are the points which we least emphasize on.
Thank you, Dr. Swati. May I just finally if all the speakers, I think if you were, because this is a Pregnancy Awareness Month, so if you were to really give one message from your own perspective, what would be that message? It could be just a sentence. Dr. Swati, we can start from you. That's okay.
So I would say, I think pregnancy is a great time. I always say to women, pregnancy is as women, we generally don't take care about ourselves. We are mostly concerned about our families and our jobs and all those things we're taking. But pregnancy is the best time for women to be taking care of themselves and treating themselves and getting the best possible best possible outcome for the pregnancy will be helpful if they take care of themselves in pregnancy. It's the best time for them.
Thank you, Dr. Swati. Dr. Caroline, what would be your message for the wider community?
Well, I think that enjoy the pregnancy, but be aware of anything that may be an indication that you need to be seen immediately.
Thank you. Thank you, Dr. Caroline. And Dr. May?
I think for me, I would say it's okay to be uncomfortable when you're speaking about pregnancy complications. So especially if you're aware of risks of pregnancy complication, and if someone's pregnant within your friend circle or family, it is an uncomfortable conversation to have with them to raise awareness, but I think it's important that we do.
Thank you. And Professor Asif Ahmed?
I'll chime with what Carolyn said. Pregnancy is a risky business, but science will soon empower women to transform lives.
Thank you. I think that's a wonderful point to really conclude. But we have also Pavan Kumar actually asked, sharing a message that predict preeclampsia, save 2 lives. And we completely agree with that point. I think that's really absolutely important. But I think in today's world, as the world is changing so. Sorry,
that's
please.
what I was going to say to Mr. Pavan. I would say that we can predict it, but to save the 2 lives, we need to prevent it, treat it.
Completely, yes, absolutely. No, but I was just reflecting on the.
Hello, sorry to interrupt you. Actually, no, I'm Dr. Maithili. Yeah. I'm Pavan's wife.
Oh, okay.
I'm an obstetrician and gynecologist.
All right.
Congratulations to all of you. It was an excellent presentation, and I went through all those slides and all, but still I have a question to Dr. Asif. I didn't understand, in his clinical trials, how many women were benefited, and actually what gestation they are trying to give these drugs, medicines, and what was the acceptance rate? I know it will take a time to accept for the woman and the clinical trials and all. I'm just curious to know about this.
Yeah, Mrs. Kumar, I can share with you the manuscript, the publication, through Pavan, if you like. But yeah, so this was the world's first randomized controlled trial of a category X drug. And it was really to see, one, the compliance, as you say, and also to see if it's safe to give. But the primary endpoint was to see if it would suppress the culprit protein, which it didn't, because this was given to women after they had full-blown preeclampsia. This was between 24 weeks and 32 weeks, or before 32 weeks, 39 plus 6 days. So, when the horse is already bolted. But what it did show, that it gave a trend towards increased gestation. So I'm confident, but it's not something I would pursue as a therapeutic from a pharmaceutical perspective. We're more about precision medicine. So we've now developed targeted therapeutics. So by predicting who will get it, we've actually shown in human studies, but more in our model systems, we've been able to show that that therapeutic can change that diagnostic into a prognostic indicator. So we know we've got it sewn up, if you like, the integrated approach. So I'm happy to talk to you. And I'll send you the information. I assume we have your details. We can email it to you.
Sure. Thanks a lot. Thank you.
Thank you. Thank you, everyone. I think it has been really a very inspiring and intellectually stimulating conversation on of a topic which really needs a lot of attention. I think today what we have gathered is actually the momentum to really, to take this to the public forum and then start debating and discussing the options and the opportunities and choices. I think we are really heading in the right direction. And as Professor Asif mentioned, that our goal should be to really make preeclampsia a history, and that would be the day that Dr. Carolyn Fahm will be celebrating, and we are very sure about that. But what an amazing panel! And may I just really extend heartfelt thanks to all the speakers. But I'm sure that Professor Asif Ahmed, do you want to say a few final words before we close this session? Thank you all for joining from wherever you're joining, and have a lovely time. Thank you.
Thank you, Professor Sabu. I think I'd like to just thank you for being a fantastic moderator, chairman of this meeting, and in giving everybody opportunity, as you always have done. You're a very inclusive person, and I just want to thank you for that, and thank the other speakers, who, Carolyn in particular, for sharing with us in public her personal tragedy, I would call it, and I'm committed to making that she can see that we can make a difference, and let's make preeclampsia history within this decade, as May constantly reminds.